So first of all, let me thank, of course, Professor Blum and Professor Zen for the very kind invitation. This is not my first time here in Nancy, and this is a slide just collecting 3 slides of my presentation back in 2000 when I came for the first time to this meeting. Probably it was the first meeting, very successful one. And I was talking about CT colonography, like today. Well, this image is just to show you what kind of image I was presenting back in 2000. And so the topic of today's lecture is what happened from 2000 onward and in the last 18 years. Well, I want to show you with a simple image. I showed you before the quality of the images at that time. That's the quality of a CT colonography today, where you see very clearly a flat lesion on a fold, and that's the corresponding optical colonoscopy. Of course, it's not only a matter of image quality, it's a matter of different technique, it's a matter of new evidences, it's a matter also of new indications. So now I will just to show you very briefly what, in my opinion, are the highlights in techniques, evidences, and indications. First of all, technique now is standardized. There are a couple of ESGAR consensus published in the European Radiology that you can easily and freely download from the web. So I don't want to talk about the technique. I want to talk to you only about something new, about bowel preparation. We know that that's the standardized technique. You need a low residue diet, you need a full dose laxative, and you need tagging. Tagging is mandatory. Tagging means you administer a contrast medium, a positive contrast medium, the day before the examination or on the day of the examination, so that to tag the fluids. It means that you can recognize a polyp if it is completely submerged on both prone and supine. Of course, you would miss a polyp if you don't tag your fluid. And of course, tagging will improve your specificity, so it makes the differentiation between a small lesion and a small fecal residue much easier. So tagging is part of the job, but there is now a new approach where, for example, you can avoid asking patient to have a dietary restriction, which is something very inconvenient for the patient. This is a randomized trial we just published a few months ago, showing that in terms of quality of bowel prep, volume, residual fluids, and colon distension, there are no significant difference if you ask a patient to follow a dietary restriction or if you ask just to eat whatever they want. And of course, you improve the patient compliance. So that's an important shift, I think, in the bowel preparation. And of course, you can use low dose or no laxative at all. That's the other important point to improve the tolerability of CT colonography. Of course, in conjunction with tagging for sure. What it works, well, there are many options if you go through the literature with variable results. What I can tell you, what it works in our opinion, you can reduce by 1/2 the dose of polyethylene glycols. If your colonoscopy gives 2 liters, you can easily give 1 liter to your patient the day before the examination. Of course, on the day of the exam, you can deliver a hyperosmolar contrast medium, 1 millimeter per kilogram of body weight, so you minimize the volume, and you take your examination 3 hours later, and you get good quality. Or you can avoid using laxative at all, and of course you need to use the day before a hyperosmolar contrast medium at a higher dose, at least 160 ml. The other important difference compared with the images of back to 2000 is radiation exposure. You know that radiation exposure was one of the sources of major concerns from the gastroenterologists. Most of the critical issues they raised in their papers were about the radiation exposure. Of course, if you follow the current ESGAR recommendation and you deliver more or less 5 millisievert on your examination, The risk-benefit ratio, so the risk of radiation versus the benefit of detecting either a cancer or a polyp, is absolutely in favor of the benefit, 24 to 35 times higher. But nowadays, you can easily perform a CTC with a sub-millisievert technique, so delivering less than 1 millisievert. So the dose exposure is much, much lower than the natural background, which, as you know, is about 2.5 or 3 millisievert per year. Of course, if you use the iterative algorithm, which improve the image quality, decrease the noise, and maintain the same polyp conspicuity, and the image you see there, is a polyp detected at 0.7 millisievert. So what about the evidences in terms of results? Now, I want to give you a critical approach to the data that we have in the literature. First of all, let me sum up the data. Well, the bunch of evidence that we have for CTC is probably not available for any other diagnostic test. There are 4 randomized clinical trials, which have the highest evidence, as you know. There are 2 multi-center trials, 2 single-center trials, and many meta-analyses showing that CTC is as good as colonoscopy for the detection of cancer and large polyps, polyps larger than 10 millimeters. It is slightly lower compared with optical colonoscopy for the detection of small polyps between 6 and 9 millimeters. And of course, it is not suitable for the detection of insignificant tiny polyps smaller than 6 millimeters. But to be critical towards those data, is it true for all the different types of patients that we study? So those data apply to screening, symptomatic, and patients under surveillance? Well, the answer is no, or better, it is yes for screening and symptomatic, is no for surveillance, because now there is a paper which is published online. It will be released in the next few months. It's a prospective multi-center trial targeted on patients with a previous colorectal cancer resection, studied at 1 year with colonoscopy and CT colonography. And unfortunately, in this multi-center trial from the US, the detection rate for polyps in this subgroup of patients is much lower. It's 44% for any lesion larger than 6, 77 for any lesion larger than 10, and the data, they don't change that much if you stratify and you avoid all the hyperplastic polyp and you concentrate only on adenomas. Of course, looking critically to the paper, we must say that the anastomosis was evaluated similarly by colonoscopy and CT colonography, and in 2 cases of extraluminal recurrences, it was only on CTC that it was the radiologists were able to detect the lesions. Of course, the lesion was not detected with optical colonoscopy. But the polyp identification rate, of course, is higher for optical colonoscopy, and probably there were some problems in the distension, especially in patients with the right hemicolectomy, the loss of the ileocecal valve. So probably the poor distension of the colon affected the bad results. But that's an area where we should need more investigation. The second point is, do the results I show you apply to any kind of lesion? Well, they apply to polypoid lesions. So we are very good in detecting polypoid lesions. But what about non-polypoid lesions, flat lesions? Well, honestly, if I look at the literature, I must conclude that there is no robust evidence to tell you how good it is CT colonography for the detection of non-polypoid lesions. This is the most recent paper. It is the prospective trial conducted in Japan on over 1,200 patients. And of course, the detection rate is not as good as for polyps, but is not as bad as you might think, because you see that flat lesions were detected with sensitivity ranging between 60 and 70%, lower than polyps, but not zero, for sure. The last point is about the serrated polyps. If you go back to your hospital and you talk with your colonoscopists or gastroenterologists, they will inform you about the serrated polyps. Serrated polyps is a new entity. The hyperplastic polyps that we know very well, those are non-significant, non-cancerous polyps, are part of the serrated polyp family. But in this family, there is another group of polyps, the sessile serrated polyps, which are usually flat lesions located in the right part of the colon, and probably those are the ones responsible for a third of sporadically occurring colorectal cancer. So the cancer that even with colonoscopy, we are not able to prevent. So the question is how good it is CTC in detecting serrated polyps. There are some bad results from the randomized clinical trial from the Netherlands, where they analyzed the subgroup of serrated polyps among the entire population, and the detection rate for CT colonography was less than 1% versus 4%, which is what we might expect in a screening population for optical colonoscopy. And unfortunately, in that study, none of the flat high-risk serrated polyps was detected by CTC. More encouraging results were published in the same years by the University of Wisconsin, where the overall detection rate for serrated polyps for CTC was 3%. So if you consider that more or less the prevalence should be around 4 or 5%, we are not that bad. Of course, to detect a serrated polyp in the right colon, you need to have a high-quality examination. A radiologist should be aware of that type of lesion, and we should know some of the tricks, like, for example, the surface contrast coating. In most of those cases, those flat lesions are covered by a layer of the contrast that we deliver for tagging. So this contrast tagging might help us in making a differential diagnosis between a simple hypertrophic fold versus a real flat lesion. The last few minutes about indication. I think on a political point of view, the most important goal that we reached in the last 18 years was to create a consensus with the European Society of Gastrointestinal Endoscopy, the SG, which is the leading society of endoscopy in Europe. And it is the society which publishes its works on endoscopy. So we were able to create a consensus statement with them and to publish the recommendation for the indication to CTC on both European radiology and endoscopy. And both societies, of course, recognize CTC as the radiological examination of choice in the context of colorectal neoplasia, and both societies discourage the use of barium enema. That's, I think, the most important goal. Then we can go through the different indications. I don't want to discuss. The indication on the left side are the indication that we agree with the endoscopists that we should or they should refer patients to us for a CT colonography. Today I want to discuss with you only the colorectal cancer screening, the population screening. Of course, based on the recommendation published 2 years ago, CTC cannot be recommended as a primary test for population screening, at least in France or even in Italy, because we follow the recommendation from the EU, which tell us that we should use FOBT or FIT, fecal immunochemical test, for population screening. But there are now accumulating evidences that in the near future we might replace FOBT or FIT with CT colonography. Of course, we need CT colonography needs to fulfill those 4 criteria, which are the leading criteria for a test to be acceptable as a screening test. So first of all, acceptability and efficacy. So if we offer the test for free, how many people would attend the test? And there are evidences for a couple of Italian studies and one study from the Netherlands, randomized trial targeted on screening population. And you see that the participation rate for CTC is between 25 and 34%. So less than the first round of fecal occult blood tests, but higher compared with other screening tests like flexible sigmoidoscopy or colonoscopy, if you want to offer colonoscopy as a primary screening test. And in terms of the detection rate for advanced adenoma is in the area of 5 to 6%, which is lower than colonoscopy as expected, and as I told you before, which is around 7 to 8%, but much higher than flexible sigmoidoscopy, which is used in the UK or in north of Italy as a screening test, and much higher than fecal immunochemical tests, which has a detection rate of 1.7%. So in terms of participation and detection rate, we are there. CTC can be offered as a screening test. The third requirement we need to fulfill is safety, so the perforation rate in this case, not the radiation. I discussed already about the radiation. While in this meta-analysis, we demonstrated the perforation rate of CTC and colonoscopy is more or less the same, but we do not have to discuss this topic about considering the perforation, but we should discuss this topic and consider the surgical rate. So how many patients with a perforation CTC are referred to surgery, and how many patients with a perforation at colonoscopy are referred to surgery? Well, for CTC, it's only 1 every 12,000, so most of the perforation are treated conservatively, whereas for colonoscopy, virtually any patient with a perforation would be referred to surgery. And those data are now reconfirmed by a very interesting and recent national survey performed in Japan, where they stratified the perforation at CTC, and based on the new Japanese data, the perforation in screening is at 0.003%, so 10 times lower compared with the perforation rate of colonoscopy, and the surgical rate for CTC in screening is even higher, so 1 every 30,000 patients and not 1 every 12,000 patients. So we are even more safer than what we demonstrated with the meta-analysis. And the last point is cost effectiveness. We can be a good test, we can be a test accepted by patient, we can be a safe test, but if we cost too much, we cannot afford as a screening test. Well, in terms of cost effectiveness, most of the papers published in the literature, which were based on mathematical models, show that CTC was dominated by colonoscopy or a combination of fecal cord blood test and flexible sigmoidoscopy. So we were too expensive. But now we have real data, not mathematical data, we have real data from the Italian and Dutch trial showing the average cost of CT colonography for screening in the Netherlands, 170 euros, and in Italy, almost 200 euros per patient. So if we put those drivers, those inputs, those costs into the models, probably the outcome of the model will be completely changed. So CTC might be considered absolutely cost-effective for screening. And that's where we want to work in the next few years. So just to conclude, success consists of going from failure to failure, and that's what happened to CTC. We had many failures, we still have failures, but we never lose our enthusiasm. And in the next future, I'm sure that we will see CTC as a screening test for our population. Thank you.
Merci, professeur Laghi, pour cette présentation très enrichissante. Je voulais juste vous dire, on va ouvrir pour les questions pour professeur Laghi parce que le sujet change pas mal. Et j'aimerais vous demander de réfléchir bien aux questions que vous allez poser au professeur Siegel pour la fin. Comme ça, on pourra un petit peu plus de temps de débat à la fin de la séance. Alors, si vous voulez, maintenant, les questions pour professeur Laghi, s'il y en a dans l'audience.
Je vous félicite pour la présentation. Congratulations for your presentation. Et un commentaire pour tous nos radiologues ici présents, nos manipulateurs, enfin tous ceux qui essaient de faire avancer les choses pour les patients. Je peux vous dire que dans mon agence régionale de santé Hauts-de-France, où il y a plein de bonnes choses, hein, il y a des professionnels de santé qui réfléchissent avec nous. Pour le prochain programme régional de santé numéro 2, qui se met en place dans toutes les régions, on avait comme résultat la possibilité d'avoir pour les 5 ans qui viennent 5 scanners et 7 IRM. Je ne pouvais plus en dormir, c'était en décembre. Je n'ai pas beaucoup parlé d'Alain Ramoni, je n'ai pas arrêté de lui parler de ça, c'était notre combat pour 2018, tous ensemble. J'ai travaillé avec tous les membres de la commission de l'organisation des soins, je les ai tous vus, il y en a une 50aine, notamment le représentant des patients, disant que ce n'était pas possible. Et pour le scanner, j'ai mis en avant 4 idées. Le scanner interventionnel, qu'on va débattre beaucoup pendant ces sessions, dont on va beaucoup parler. le dépistage en coroscanner, en coloscanner. Et aussi les évolutions technologiques qu'on peut pas... Dites-moi où on peut faire facilement de la perfusion. C'est difficile et c'est pas valorisé. Donc c'est vraiment incroyable. Et regardons aussi dans nos régions s'il y a des scanners d'urgence partout, notamment dans les centres qui ont 30 000 à 40 000 passages. Donc on a été très bien reçus au niveau de l'Agence régionale de santé. Et la conclusion du directeur de l'offre de soins a été, après l'exposé, qu'ils adapteraient le nombre de scanners et d'IRM aux différents projets médicaux. Donc vraiment, je profite de ce scanner. J'ai donné à la directrice d'agence le programme très bien fait par Marc et Alain. On a de la chance d'être ici. Et il faut que ce programme soit adressé à toutes les ARS et qu'on puisse expliquer pourquoi il faut faire un coloscanner, pourquoi il faut faire un coroscanner quand on a la soixantaine, par exemple. Et il faut vraiment le faire. Et ce coloscanner nous aide. Et évidemment, on s'entend bien avec les gastroentérologues. Il y a encore des bonnes indications de coloscopie sous-âgée. Mais il y a tellement de possibilités. Et je peux vous dire, dans ma région, j'ai fait une enquête. Je vais être très bref. Les gens disent, bah oui, on aimerait bien faire ça, mais quand on appelle, on dit oui, on n'a pas trop le temps, on n'a pas trop de place. Les radiologues n'attendent que ça, d'avoir plus de scanners. Ils ne peuvent pas s'organiser. Il y a quelques centres européens ou à Paris, et j'adore tous ces centres parisiens qui ont pu s'organiser, où finalement, des gens de ma région me disent on est allé à Paris et ça a été très bien. Donc je ne dis pas qu'il n'y a rien qui est fait chez nous, mais il y a très peu de possibilités pour nos radiologues qui sont pourtant bien organisés d'avoir un accès. Donc c'est un plaidoyer pour ça. Thank you very much for your presentation. Et il faut qu'on change nos habitudes, et il faut qu'on se serve de ce programme pour qu'on puisse mettre en avant nos innovations. Le quatrième point que je voudrais vraiment insister, mais c'est ce programme aujourd'hui, c'est nous laisser le temps pour mettre en place nos innovations en scanner. Ça prend un peu plus de temps que les scanners normaux, et valorisons ce qui mérite de l'être.